Now 3 minutes.
Yeah, here there 2 minutes 49 seconds. But tell the you want to give the age name of the patient.
What is the command age and other?
Age is 1.5 year. 1 year. Okay, keep 1 year.
Okay.
And please give your comments on the video.
Okay. I can see a child 1 year old who is in the hospital setting, lying supine with eyes closed, who has significant stridor with intercostal and subcostal retractions, and also I can appreciate, I think, little cyanosis there, but he's not on any oxygen around the lips, but he's not on any oxygen or any device connected with him. And also taken also some notes of the abdominal breathing.
What breathing?
He was taking the abdominal breath because of the distress, because of the respiratory distress.
Okay. What history would you like to ask?
I would like to ask that he was having any fever, any history of fever, or the child was playing around the kids, any history of sudden stridor, sudden difficulty in breathing.
What else?
Hello, can you hear me? Oh, okay. And I can also ask that whether this stridor is since birth or it is a new stridor.
Okay. Then what particular examination would you like to do in this?
Okay. I will particular examination for this. I will do the vital signs. I'll check the vital signs of the patient, blood pressure, especially the saturation, heart rate, and also I will auscultate the heart for the other sounds, like if he has stridor, if he has other wheezes, bronchitis, or only this stridor is there. And I will auscultate the also heart.
Okay, auscultate heart and respiratory examination.
Respiratory examination.
Okay. What else you want to do the examination?
Blood pressure, heart rate, oxygen saturation,
okay.
And RR, his
so,
RR.
What investigation would you like to do?
I would like to, first of all, I would like to see the saturation of the wave. If the saturation,
differential diagnosis first, differential.
Yeah, differential
Okay.
diagnosis.
Okay, differential diagnosis. I can go like if it is viral or bacterial. If it is viral, it could be croup. Or if it is bacterial, I could think about the bacterial tracheitis. And if the child is in more sick and with fever, I can think about the epiglottitis. And also I can think about the foreign body aspiration if there is a history of sudden respiratory distress and child
Okay.
playing around other kids.
So what
These are the main
investigation?
four
What in
of
investigation would you like to do?
if it is if it is, I will think about by my differential diagnosis. If it is viral group, I'll just see that whether his saturation is normal or below the normal. So we'll start him on oxygen and we'll observe. And if it is like severe, we will sometimes they will just group only observe and give them steroids like dexamethasone. But if it is like
Okay. How will you manage?
croup usually mild, moderate, severe. If mild, just you will
No,
see this. Like
this one, tell about this one only.
this one looks to me the severe croup. For this
Okay.
one,
How will you manage?
I will keep the child calm. I will not disturb the child. I will not do any examination of the throat. I will not do any cannulation. So I will keep the child calm. I will start him on oxygen. I will give him steroids and dexamethasone and sometimes the nebulization. But for this patient, I will give the adrenaline nebulization also. I will also alert the ENT team and PICU. If like suppose child goes worsens the condition, he might need to go to be admitted in the PICU. So they can be the one who will manage him for intubation, ENT and PICU team. And of course, the hydration, we'll start him on IV fluids. So from the beginning, I will keep him calm. I'll start oxygen. I will give him hydration with the fluids. I'll give him dexamethasone and adrenaline nebulization. And I will contact with the ENT and PICU team. And this is for the group. If it is bacterial, I will think about also the antibiotics at that time.
Okay. Okay, time finish. Hello.
Seconds left.
Okay. So, what advice you would like to give the family
The
or mother?
parents. For the mother, I will give because there should be some mother to give some advice. If suppose we discharge the patient, we can give the advice that if he has a respiratory distress, significant respiratory distress and fever, so to come back at that time.
Okay. Okay. So I will give the feedback now. Okay. Okay. Description was, I think it was good. Just start. Like I can see one year old child lying in the bed with the in the hospital setting with no cardiac monitor or any oxygen is going
Oxygen
on.
connected. Okay.
Yeah, oxygen connected or cardiac monitor connected, and he's at the moment in distress in the form of respiratory retractions, subcostal intercostal sections, and I can appreciate mild cyanosis, and he's having the stridor on rest. Okay.
Strider
This
on
is,
rest. Yes. Yeah.
yeah,
This
this
is
is
the main
the
thing here. Yeah.
main thing. Cyanosis, I am not looking. This is baby cyanose, but if you are still
But
considering this is mild
I said
cyanosis,
I can appreciate mild cyanosis about around his mouth.
yeah, just to
Mm.
say this is he's having subcostal intercostal
Mm.
sessions, respiratory distress
Mm-hmm.
in the form of, and the second is strider on
Mm.
rest, and for me he's looking sick. So I
Mm.
will consider it as when you are going for differential, I will consider it at severe croup
Mm.
and others like bacterial tracheitis and epiglottitis and others.
Mm. Mm.
Okay,
Mm.
in the history, you give me only two or three things. That was okay. You in the
Mm.
history, you should ask about first of all onset course duration. This is very important.
Ah,
The
yes, 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 yeah, yeah,
second thing
yeah.
should be asked about history of fever and history of similar kind of
Similar
condition
attacks.
in the
Yes,
similar
yes.
condition in the family, or anybody is having similar. History of vaccination is very important. Okay, what is the organism that may cause
Mm. Croup. Croup is usually with the parainfluenza one, type 1 and type
parainfluenza?
2.
Yeah,
Mm.
but here why we are asking about the vaccination, because
Because
for
of
the
Haemophilus,
epiglottitis.
Haemophilus influenza B, epiglottitis can be
Yeah, yeah.
vaccinated.
So should we
Yeah,
ask,
vaccination is important here. Yeah.
consider of that vaccination,
Mm.
and we should ask about history of previous history. Like in the past,
Mm.
I would like to ask about intubation. Anytime he
Ah,
has been intubated
yeah,
or
it could
not.
be. Yeah. Mm.
Yeah, this could be a reason one. Okay.
Okay, so history,
So
I should ask also the onset duration and also if there is similar history and if he has previous intubation and vaccination. This is important.
these are
Vaccination is
four.
because of epiglottitis, vaccination is important also.
And one more thing, you will ask about the activity level of the child, like feeding, how, because he is 1 year. So would
Mm.
like to ask about the feeding history also. How is he is active these days? Okay, this
Okay.
will feeding will be decreased in group. So these will be the history points. Then definitely better. I think you can start. This is kind of event. This is an emergency. So you should start with the ample, which
ABC,
is
yeah.
no ample, which I was telling
Ample.
yesterday. You were not here. So
I was not here, yeah.
history of allergy, one thing.
History
History
of
of
allergy.
medication. Okay, and P
Mm.
for previous history, and L for last meal, and E was for, I forgot this. E was, I don't know. So
Events.
I will tell.
Events happen.
Even,
Events happen.
yeah. So this one should be like this. So because this is an emergency, so should be like history should be from the emergency. Then you have done nicely, but I'm just telling few things
No, no,
which
it's
you
very good
forgot.
that to tell
Yeah.
me how I should improve. This is very good.
Okay.
Very nice feedback.
And
Yeah.
then you have given differential, that was very nicely. But in the differential,
Mm.
when we are giving the differential, so for me, which I'm considering, this is a severe
Mm.
group, but I will
Mm.
keep in my mind epiglottitis as well. But in the epiglottitis, child looks very sick,
Very
and there may
sick.
be some very sick, and there may be some drooling
Drooling.
from the mouth,
Drooling. Yeah. Mm.
and I don't, they may have high grade fever, so I cannot appreciate. In the video,
Mm.
they have not shown me anything about that, so I will
Mm.
consider it again, but I will keep it in the second or the third place. Bacterial tracheitis is similar. The child is so much
There will be
toxic.
febrile,
Yeah,
toxic
maybe
looking. Yeah.
febrile, toxic looking. So,
Mm.
and which you have said that foreign body, definitely in the history you should ask anybody
Mm.
around playing when it happened.
Mm.
So I'm ruling out
Mm.
for the foreign body as well, because
I
this
asked
child is
that if he was
yeah, yeah,
playing around and
you have
sudden.
asked, you have asked.
Mm.
So one
Mm.
year child, so child maybe
Yeah, they can
definitely
have.
will
They
be
can take
crawling.
anything in the mouth. Yeah, they can take
Yeah,
anything. Mm.
definitely they are crawling, and they are maybe cruising around, or maybe they are walking, so they can put anything in the mouth. So I will
Yes.
consider that one also in my mind. So like this you will tell. Other,
Sure. Okay.
uh, when I ask you in the labs, don't say that I will check oxygen saturation. Always start with, because you have labeled it as severe
Croup.
group. So here you
So
will
I
tell
will
like
do
this.
here.
What will you say? So this is I am considering this is severe group, so
Severe group.
this should not be disturbed. So I will not
Disturbed.
do any
Do in.
laboratory
Mm.
investigation in this case, particular in this case.
Yeah, because I have to
uh,
calm, keep the calm
yes,
baby, keep the
yeah.
child calm.
So
Yeah.
I just want to check his oxygen saturation as well. But as child is having this severe group, so I
Mm.
can a little bit defer, or I can think of that. I will involve my senior. So like for this, senior should be involved in the management plan. Always start with, here we will not start with A, B, C, or, because we cannot assess for the airways, we cannot assess for the breathing or
No.
circulation in these. You
That's
will
why I
say,
said that's why I said
yeah,
starting from oxygen. I will
yes.
start on.
So first of all, what will you say? First of all, these childs should be uh, should be treated
Not disturb.
in, yeah, should not be disturbed. I will not disturb the child. I will keep calm the child and keep calm the parents as well. This always tell parents, educate the parent,
Parents,
educate
education.
the parent, and I will uh, treat him in the comfortable position whatever he is having. Okay, the same position, comfortable position what he is having. Then if he's required oxygen, then I will give the oxygen as well via face mask. This will be, I think they have written 15 liter or something. They have written in the guideline.
Yes,
So
15 liters.
yeah. So then
In
what
the
will you do?
in the guideline they wrote keep high flow 15 liter via mask with reservoir bag,
Yeah, but
which
you
must
should
be
tell
prescribed.
always. I don't want to disturb, but if the child required oxygen, so definitely I will go for oxygen. But telling
Oxygen.
after informing my consultant with 15 liter via face mask or nasal cannula, 2 liter will be nasal cannula. We are giving the less. So then you should tell about that dexamethasone
See, this
oral.
one I read from the guidelines. Keep the child and parents calm. I forgot.
Okay, then you should tell that dexamethasone should be given oral if he cannot tolerate. So I will do the nebulization with budesonide. Okay,
Budesonide or
Nebulize,
adrenaline?
budesonide nebulization is first.
Okay.
Then the second nebulization will be adrenaline.
Adrenaline.
That can be repeated after how many
Uh,
times? I forgot this one. 30 minutes or something, or 5 minutes. No, no, not 5 minutes. I
no,
think
not 5 minutes. It was
30 minutes.
what I read, 30
30
minutes,
minutes.
I think. I
Yeah,
also
yeah.
read it.
So this one, then I ask you what advice. For the advice, you will give the, if anytime child is start drooling from the mouth, become cyanosed, become severe in distressed,
Distressed.
not taking feed,
Yeah, it can be repeated after 30 minutes. I read
yeah,
from
not
the
taking
guidelines.
feed. So then you should come back immediately. Okay, this is so few things which you forget and other things you have told. So for me, this one only.
Okay, that's good. Okay.
Okay. I have some
So
questions.
that one regarding it, because this is severe, it can worse. So that one about the PICU ENT after the all those nebulization and all those we have to mention in management, right?
Okay, I will tell some points now.
Yeah, you can
Okay.
tell I'm going now actually on
Okay,
the
okay,
road.
doctor. No problem.
Okay. So the points here, before that, what are the things Dr. Adnan covered everything in your history. You did not ask about vaccination history.
Yeah,
Uh,
vaccination I did not
Onset
ask.
course duration. I'm just repeating so that we will not forget in the next case. Onset course duration, like when did it start, how long it is, and sometimes the child may have chronic croup and now it has become acute teeth infection. Also can happen in an laryngomalacia case, right? So you should also know any past history of similar problems and was it severe, was it okay, like this. And vaccination history, in any intubations in the past, because it can cause
I think this one
stenosis.
stenosis in the epiglottis.
Yes.
Epiglottic stenosis from the previous intubation, if long time intubated.
Yeah, stenosis in the glottis, what we call it as even subglottic stenosis can happen here.
Subglottic stenosis can also happen.
So intubation, then activity level of the child, how is he feeding, how is he playing, all those things. Usually we ask this in general, how is his activity at home. Okay. Then foreign body, for foreign body, anything he was playing and he is putting in the mouth, like this, right? For foreign body. Next, what when you are telling nursing in these children, you can also say, as Dr. Adnan said, keep calm the child and parents. It is always better to nurse the child on parents' lap.
Parents lab.
Because they will not get distressed on the parents' lap, and do not distress the child. So you will not do any, you will not take any lab investigations here. And also oxygen also you will give carefully, even with the face mask. Maybe he will get distressed with it. Okay.
They wrote in guidelines to give them high flow oxygen 15 liter via face mask. If he is requiring, like if he is having low saturation below
Low
90.
saturation, less than 92% cyanosis, poor respiratory effort. And sometimes if in this situation, the child may have altered level of consciousness also. So you can give, no problem, but you have to be careful that you should not make him distressed. This point is very important. So for the hydration, be careful. To give the hydration, you have to put IV line. So
IV, but here we cannot.
Before suppose if you are suspecting this child is toxic and bacterial tracheitis or epiglottitis, you want to put IV cannulation, you will not put IV cannulation by yourself. It had the consultant and the ENT and the anesthesiologist, all should be there. Because if needed, you have to intubate the child.
Intubate the child.
Or if you are so much afraid of the airway, they have to be intubated and securing the airway, then only you have to take and then only you have to put the IV line.
Yes, okay.
Okay, if you have to go for IV line, you will not go by yourself in these patients. You will always involve your consultant and anesthesiologist and also ENT. Sometimes ENT, why ENT here?
He might need sometime the intubation through ANT. They are more expert this. Or
anesthetist is for intubation. ENT, they may require tracheostomy also.
Tracheostomy, yes, tracheostomy.
That is why, okay, they may need tracheostomy sometimes. So you have to involve the pediatric anesthesiologist and be ready for the intubation, because these children can have difficult intubation because of the swelling in the larynx.
Okay.
This is inflammation of the larynx, right? Because of the swelling in the larynx and also epiglottis, in epiglottitis, you may have difficult intubation. So if the intubation is failed, you may also need to go tracheostomy. So all should be there: anesthesiologist, ENT, and your consultant pediatrician. The child should not be disturbed. And before, you have to secure the airway before going to the IV line. Okay.
Okay.
Okay, this is the thing. And for the advice to the parents, as he said, drooling, if you discharge the child, okay, suppose if it is mild to moderate, you want to discharge the child, how long you will observe the child in the
4 hours. 4 hours in the
you will observe the child for 4 hours. Maybe in mild to moderate, what medication you will give?
Mild to moderate, we'll give the mild, we don't give the steroids, but in moderate they give steroid dexamethasone.
No, you can give dexamethasone, because here it is written both for mild to moderate.
Mild also, mild to moderate.
You can give, if yes, you can give 1 dose, single dose of oral dexamethasone, and you can observe the child.
Moderate, you have to also observe 4 hours in that.
Yeah, moderate, you have to observe for 4 hours. Then if you want to discharge the child, what you will advise the parents in moderate?
You will advise them that if child is having respiratory distress, any fever, or any not taking the feeds well, or any like drooling, if has any drooling sound, drooling, respiratory distress, not taking any meal, so to come back to the ER.
Yeah, and also the other important red flags, like serious red flags.
Cyanosis also.
Cyanosis. Stridor, still the stridor is present. Stridor at rest. Cyanosis. Persistent fever. And also reduced level of consciousness and confusion, something like the serious signs also you will tell them. And also you will discharge by giving them to give 1 more dose of prednisolone after 12 hours if you are discharging the child.
Okay.
If you are discharging the child, you have given 1 dose of dexamethasone now, right? Usually you are giving 150 micrograms per kg, but dose, I don't know. It's a common drug which we use in all children. So let's tell it. Dexamethasone 150 micrograms per kg, you give one dose.
They said in the guideline, they said 150 microgram per kg oral. But if the child refuses to swallow oral medication, then you give nebulized budesonide.
Yeah, nebulized budesonide 2 mg. It is the
2
dose
mg.
2
Yes.
mg.
2 mg, yes.
Now, what you will do, suppose you want to discharge the child, you reassessed after 4 hours, he's fine now. But you will not just discharge him. You will give them one dose of prednisolone to be used after 12 hours.
Okay.
Okay, you will discharge him on prednisolone 1 mg per kg, and you will advise the patient. Suppose now you gave in your department at 6 a.m. You will advise the parents to give him at 6 p.m. in the night. That is 12 hours.
So one dose with the parents.
One dose you will discharge. Suppose you are admitting the child for observation in moderate cases, you will repeat after 12 hours one dose. This is management for moderate. Okay. Moderate. And for severe, you all discussed very well. One is nursing the child on the parent's lap, keeping calm, not disturbing, not taking IV fluids, only giving
IV fluids,
oxygen, high flow,
Oxygen.
15 liters per minute through the reservoir bag, through the mask. And you think that the child is deteriorating, you will involve your senior. And the first thing you will give is the oral dexamethasone, but most probably they may not tolerate. So you will go for budesonide 2 mg nebulization. Then you will consider adrenaline nebulization. It is usually, I think, 0.4 micrograms per kg.
Adrenaline, they said in the
Sorry, 400.
0.4 ml. 0.4 ml.
No,
Actually, 400 microgram, that you are right. It is 4.4.
400 microgram, that is 0.4 ml per kg.
Yeah, 400 micrograms is given, or maximum of, I usually remember like this. I usually remember as 0.5 mg. This is how I remember, 0.5 mg per kg.
Yeah, maximum 5 mg we can give.
So for a 10 kg child, I can give, for 10 kg and above, I can give 5 mg. This is how I remember for my patients in the hospital. I always remember 0.5 mg per kg. And suppose if a child is 10 kg, safely I can give 5 mg. This is how I remember. Okay. But here he has given 0.4 mg. So maximum is 5 mg. Okay, no problem. That is not the issue. Then after budesonide nebulization, you will give him adrenaline nebulization.
Adrenaline nebulization.
You can repeat adrenaline nebulization after 30 minutes. Why you have to repeat adrenaline nebulization? If this is asked, what you will answer?
For this airway swelling.
No,
reduce the equivalent then?
No, because the duration of action of adrenaline is short.
Short duration.
Short duration of action. So you will repeat it again if needed till you are using adrenaline just to control this stridor till the action of budesonide and dexamethasone is started. You are using this to buy the
time. To buy the time.
Yes, to buy the time, because the dexa and adrenaline, budesonide will take some time to act. It will not act immediately. So for immediate action, you are using one dose, and if needed, you will repeat second dose in 30 minutes.
30 minutes.
Okay. And this is the emergency management only you will do. Oxygen, budesonide, and adrenaline. Then you will involve your consultant for any further management. Consultant, ENT on call, and anesthesiologist. Suppose if the child is drooling, very sick, if the child is drooling, very sick with stridor, so you will not give this child IV antibiotics by putting cannula. He has to be either in the emergency resuscitation area, ready for intubation, or with the
PIC.
or even in the operation theater if they need also tracheostomy needed. Okay. See what he has written in the guidelines here. After the first 3, contact on-call consultant pediatrician urgently to assess clinical situation. Discuss whether to involve on-call pediatric anesthetist and ENT surgeon. If no sustained improvement with adrenaline and dexamethasone, if you don't see adrenaline and dexamethasone, secure airway by experienced anesthetist and transfer to PICU. He is telling in theater. Why it is in theater? Because suppose you failed with intubation, maybe he need tracheostomy. Okay. This is that is why he is telling. So if you don't see any improvement with adrenaline and dexamethasone or budesonide, you will shift the patient to theater to secure the, before going for labs or anything. Okay, this is the important point. So Dr. Yasser, you have anything to add?
No, everything has been discussed, so nothing to add.
Okay. So we will go for the Dr. Adnan is here or he is still out. Hello, Dr.
I'm traveling.
Okay, so this case, Dr. Yasser will be the role player. So I will do then if you are not free. Okay.
No problem, you can do. Actually, too much here. Still on the road. I don't know. I can speak, but there will be disturbance. Actually, I can speak, but there will be disturbance.
Okay, next case, maybe this case will take some half an hour now. Maybe by that time you will be free, I believe, right?
Yeah.
Okay. Just let me know when 3 minutes finishes. Sure.
Constant cough. All right. You run the fever at home. Constant cough. All right. You run the fever at home. Constant cough. All right. You run the fever at home. Constant cough. All right. You run the fever at home.
Okay, enough. So now I will, once 3 minutes finish, please tell me. Huh? Okay. Now. Okay. So in the video, I can see a 9-month-old child in the hospital setting, looks to be in distress, coughing, and is attached to the cardiorespiratory monitor. And there is an oxygen given to him through the tube. Oxygen is given and he is continuously coughing, and also it's shown that he is RSV positive for respiratory syncytial virus. So with these findings, I want to ask about the history. In the history, I will ask about the onset, duration, and progression, when the condition started and how long it is and how is it progressing. Then any history of fever, and I would like to take the feeding history and vomiting, not taking any feeds, and anytime any blue around the lips, that is cyanosis, and any apnea I will ask, and also any past history of similar conditions and admission to the hospital with similar condition. And also I would like to ask about the delivery history. During delivery, is the child born preterm? Any heart conditions does the child has? All these things. Okay.
Okay, what is your diagnosis?
So before diagnosis, we'll go for examination. Okay. In the examination, I will, since the child looks in distress, I would like to check his airway, breathing, circulation, stabilize the child, check his RR, oxygen saturation, temperature. And also I want to do complete respiratory examination and cardiovascular system examination in this child. Okay. Okay, now you can ask.
Okay, what is your diagnosis?
Yeah, my differential diagnosis most likely in this child has bronchiolitis. And then I at the same time I would also like to rule out pneumonia. And also I want to, I would have asked family history of asthma, because sometimes can have early asthma in this age. So bronchiolitis, pneumonia, early asthma, and if any associated congenital heart disease.
Okay, how would you manage the explanation?
Yes, for the management, as I told earlier, I will do the airway, breathing, circulation, stabilize the patient by giving oxygen. And if his oxygen saturation is less than 92%, I want to admit the child and nurse him in the cubicle, in the same cubicle as other children, and give oxygen by nasal cannula or by face mask if needed. And usually heated humidified oxygen can help. And I would like to involve my consultant, and other drugs like antibiotics and steroids are not helpful in this patient. And if the feeding is less than 75%, I want to give IV rehydration to this patient and admit the patient. If the patient is less than 92% oxygen saturation, cyanosis, apnea, I will admit in the intensive care unit. Otherwise, he can be admitted in the ward for oxygen and IV rehydration.
Okay, what other parameters you want to discuss in treatment management?
So humidified oxygen and IV rehydration. And I want to take the swab for RSV.
Okay, what are the investigations you want to do?
If the child is toxic, I can also do a chest X-ray to see if there is any pneumonia.
Okay, okay. So first of all, in the examination regarding the clinical finding, okay, you see he's fisting. He's doing fisting, so it's a sign of hypoxia in small children. Second thing, examination is these findings are okay. Examination is okay. Then we come to the
Dr. Rehana, 6 minutes finish or still time remaining?
No, 4.5 minutes finish. Like 4 minutes 40 seconds finish.
Okay, still 1 minute is remaining. Okay, no problem.
Still 1 minute.
Okay. So tell Dr. Yasser.
Yeah. In examination, only missing is fisting. Second thing, in clinical description, examination okay. Then we come to the diagnosis. Diagnosis okay. Differential diagnosis also okay. You put all the differential diagnosis, the most common one, and this one in investigation. Ideally, we need this blood culture. If temperature is more than 39, 38.5, there is sepsis. Swab only needed when there is flu season is ongoing and patient are immunocompromised, where we have to start antiviral medication. And third, we need a chest ray do only where there is atypical finding. Yeah, patient is a case of heart failure.
Cardiac murmurs.
Yeah. Patient is a case of known case of cardiac
Finish
heart
6
disease.
minutes finish, huh?
Also having some localized
Dr.
finding.
Yasser, please repeat this now what you said. Before,
1 minute,
after
1 minute,
6 minutes
second,
finish,
1
you can
second,
continue, huh?
Okay, sorry.
Okay, you told if the temperature is more than 39 and the child is septic, I will do CBC, CRP, blood culture.
No. Only blood culture.
No CBC, CRP.
We cannot do anything in the CBC and CRP. It's sepsis.
Okay.
Here, according to the guideline, blood culture, they say if temperature is more than 38.5 and there is high risk suspicion of sepsis, so then you can take blood culture.
Okay. Then.
Okay. Then chest X-ray if it is localized finding.
Localized sign, cardiac murmurs.
Yeah, known case of heart disease. And third is if it is more than 18 months, atypical presentation.
Atypical presentation.
Then you can take.
Atypical, more than 18 months is atypical presentation.
Yeah,
usually bronchiolitis is peak is from like up to 2 years, but atypical they said in guideline more than 18 months.
This is Red Book only, huh? Because
Red book guideline.
in this case, okay, no problem. So very
Red
good
book.
points. Chest X-ray, if I am listening, localized lesion, known case of congenital heart disease, and more than 18 months. Okay, then.
Yeah.
Then the nasal swab. Nasal swab we can do only when there is a seasonal flu is ongoing. And the second thing, if the patient is immunocompromised and we want to start the antiviral treatment, just like having some cardiac, lung, liver, kidney, or some malignancy, and immunocompromised patient, we have to start antiviral treatment.
Plan antiviral treatment.
So that's the reason we need swab. And
this swab is for influenza, ostelmivir, to give ostelmivir.
This is
this swab is for
respiratory panel.
PCR.
Yeah, this is a respiratory panel. It will tell us either this is influenza. This is a long list of viruses. They are taking from the nasal swab.
Yeah.
And just like COVID, they are taking. So it is just
there are multiple viruses: adenovirus, rhinoenteritis, influenza A and B, this RSV, and this is a PCR. It's a chain. Multiple
panel will cover even RSV, right? Everything.
It's called a respiratory multiplex. It's having multiple viruses: adeno, rhino, enterovirus, and then this RSV virus, and then influenza A, B, parainfluenza. Yeah, all those viruses.
All those parameters. They are. This we can say nasal swab only for viral PCR.
Just say viral nasal swab.
Next, we come to the CBG, this arterial blood gases. If the saturation is less than 90, and this TCO, the transcutaneous oxygen CO2 is more than 6, and the patient is severe respiratory distress. So then we have to take this arterial blood gas.
Okay.
Okay. Then we have to take monitoring management. Now we come to the management. As you tell, we have to maintain airway, breathing, and circulation. In airway, we have to nursing. In nursing, we have to clean the nasal and oral secretion by putting normal saline to the nose.
Suction.
Normal saline drops. Normal saline drops with the nose, then you can suction the airway.
To keep the airway patent. Then we come to the breathing.
Okay. Yes, airway.
Everything is written. Everything is written. No need to write.
Tell because it will make us now. Then I will go back and read. It will be fine. Okay. Airway, we will do suction, nasal drops. Then
for breathing, as you told, we need oxygen. We need oxygen. As you told, if saturation less than 90, we increase the oxygen flow. Initially, we can give through the mask, face mask, by having reservoir. And if it is not controlled, we can either use this face mask or by the nasal cannula. But if it is less than 5 kg and less than 5 kg and small baby, we have to use 1 liter per minute. And if they are more than, I forgot the year, more than 5 kg, we have to
more than 5 kg and less than 5 kg they wrote in that.
Okay. I forgot ages.
5 kg, I think 2 liters.
Yeah,
more than 5 kg, 2 liters, and less than 5 kg, 1 liter.
Okay.
Then we have to observe. 1 hourly, and then we have to monitor again. If still he's not improving in the form of respiratory distress and heart rate, then we add on this nasal cannula.
Humidified oxygen.
Yeah, all is humidified. All oxygen is heated, humidified, high oxygen. We can increase up to 20 liter per minute by nasal cannula. Then if he is not improving, then we go to CPAP. CPAP indication, if it is respiratory distress rate more than 60, this what is called TCO, this transcutaneous carbon dioxide is increasing more than 3 kilopascal. And then there is metabolic acidosis, pH 7.2. Then we consider for this, and he is not improving by all the maneuvers, this humidified oxygen. So we can go for CPAP.
Okay.
Okay. Then we come for this hydration and electrolyte imbalance. As you told, the feeding, ideally we have to maintain feeding if the patient can tolerate, and if he can tolerate, okay, we can keep. But if he is not taking, and we are considering he needs more, so we can put nasogastric tube, and then we can
NGT,
keep feeding. But if that he has respiratory distress more than 80 per minute, and you consider that his condition is respiratory condition is deteriorated due to his NG feeding, and patient is severely sick, so we hold and we put on IV fluid. And in IV fluid, we have to keep 5% dextrose with normal saline, and it is 80%.
What is 80%?
Ideally, we are giving.
If you restrict the fluids, you'll give 80% of his maintenance. Dr. Yasir?
Yeah, why we restrict fluid?
For the cardiac patients usually, right? If they have cardiac...
No. Actually, we have to avoid this SIADA syndrome.
Okay, syndrome of inappropriate.
Yeah, any brain and pulmonary, we have to keep.
Think about the also this.
Okay, so that's something we
Now
have to restrict.
So the choice of fluid is D5 normal saline, and it should be 80% of the maintenance.
Normal, yeah, 80% of the limit.
Okay.
Okay, then we keep to electrolyte. If electrolytes, if we have to maintain IV line, so we have to once daily or twice daily to keep electrolyte imbalance. Correct.
This is Dr. Yasir, I want to ask you one thing. This is the usual one, or this is in the shock patients, like who are in the severe distress, the 180%? Because usually we say bronchiolitis, we have to give them good hydration, right?
No, but because all the asthma and these are the for sick patients.
Sick patient. Okay, I got it. Yeah, that's why, because those who are
like
in
this
sick
patient, he has persistent coughing.
Yeah, I got your point.
Okay. Because if he's is mild variety, so we can give through oral or NG feed.
NGT, yes, yeah, that's what I read
no need
from
to,
there.
because in such patients also there is no need for maximum intervention. Just like this patient, you see there is no IV cannula.
Yeah, they wrote their normal feeds, brass bottle, if tolerated, NG feeds if he's not tolerating.
Okay. Next, we come to the antibiotics. As you see, the patient is less than 6 weeks, or you consider severe sepsis, then you start antibiotic, otherwise no need.
Okay.
And other, if any viral pathology come positive, so we have to use oseltamivir.
Like influenza test is positive, or there is influenza seasonal, and any immunocompromised patients.
Yeah.
Okay.
So these are the and admission parameter you already told, having apnea, severe respiratory distress, any cyanosis, feeding less than 75%, just like this, all the danger signs, persistent vomiting. So we have to admit, and then we have to manage conservatively, and then at the end, at the discharge, we have to guide the parents regarding this condition. And the only one thing, the hand hygiene, we forgot hand hygiene and use of reference.
This was in the management. I think you forgot this one. You said that you will admit in the same lecture. You have to say the similar diagnosis. Nursing in the cubicle or bay with the children
Yeah, this
having
one
the
Dr.
same
Noor has
diagnosis.
told. Yeah.
I told
Same
nursing
diagnosis.
this is cubicle, but I want to ask about the hand washing. I did not tell. Very important.
Yeah, hand washing important here.
And also why he has written nurse head up. I did not understand this. Why
Head
Well,
up, head
this
up.
one, I also
head
find out lot, but I cannot this splitting diaphragm.
means
Because this
what, to prevent this Harrison sulcus or what? This is my
it's splinting means to hold the, you can say, rest the diaphragm. I don't know.
That way
Okay,
it will be
means
rest.
head up to maybe we have to keep
nurse head up means what, up to 45 degree or something
yeah,
like
30
Like
degree.
we're
30
keeping
degree
the
we are doing.
head up 30 degree head up in the bed, like keeping the inclined position.
Mm-hmm. This will help in splinting the diaphragm.
Yeah.
It will reduce splinting. He has written reduce splinting of diaphragm. I don't know. We have to check what exactly he wants.
Because I check splitting of diaphragm, they're saying the movement of the to stop the diaphragm.
But he has written reduce. That means to make the diaphragm work better, I think.
Maybe we can make a position, so that's the reason. It's a normal position, it helps a lot.
So nurse head up, at least we have to remember this. And also the important point I missed in the management was the suction. Suction is very important here.
Just like you may remember
Also for the
airway breathing and
risk
circulation.
of also for the risk of aspiration. If you keep inclined, it will not aspirate. Child will not have aspiration.
Yes.
Yeah, that's all.
Yes, Dr. Yasser, what you are telling?
You can, as you already told, we have to maintain airway breathing and circulation. You can do, I can, because respiratory, airway, I can do this suctioning and his positioning. In breathing, I will keep saturation more than 92%, and by this maneuvers. And in circulation, you said I have to keep him feeding if he can tolerate. If not tolerate, through NG. If he is not fulfill the criteria for NG feeding, we can go for IV fluid.
Yeah. One more important point here for NG feeding is this should be, their reflex should be intact.
Yeah.
This is very important. When you are putting the IV fluid, you have to test for that. Means when you are putting the NG tube, you have to test for the airway protective reflexes are normal. When you are suctioning, then only you can go. But if the child has poor sucking or swallowing and breathing, the best is IV fluids.
Yeah.
Okay.
What are the air protective reflexes?
You mean the gag reflex?
Yeah. Number one is gag reflex. Second thing is closure of the pharynx, larynx.
Cuff reflex, no?
Yeah.
Closure of what?
Closure of epiglottis.
When you cough, also that is one reflex, no? Cuff reflex, gag reflex.
Yeah.
Gag reflex. Closure of epiglottis, what do we say? Is there any name for that?
They're written just like in the Google, I check, they say closure of the epiglottis and swelling reflex. And there are 3, 4, I forgot one.
Swallowing reflex, you are telling?
Yeah. Just like we are eating. So, when we are eating, our nasopharynx block, our airway block to avoid aspiration.
Yes, epiglottitis will close the airway mainly.
Yeah. Okay, then we need monitoring. Monitoring is the same, same just like this one. Means the saturation we have to monitor. We have to monitor heart rate. We have to monitor this transcutaneous CO2 and fluid balance. Okay, only 2 criteria to discharge. when he is fully fit and saturation more than 92%.
Okay.
Okay. Another thing to need follow up if he is on if he was intubated or ventilated and consolidation, and he is preterm and having chronic lung disease. These are the 3 parameters in which he needs hospital follow up.
Yeah. And I have seen also these children, small children with chronic lung disease or congenital heart disease, they will be given in the winter season this flavizumab, right?
Yeah, plevizumab. This is the for RSV. Those who are with the congenital heart disease or chronic lung disease.
Yeah, I have seen that I think from November to February or something, these 4 months, every monthly once they will receive the injection.
6 months they will receive.
I don't know, 4 months or 6 months, something like this.
6 months, 6
winter
doses.
months,
6 doses.
they will receive the injection,
Because
flavizumab.
winter start from October.
October, November, December, January, February, March. 6 months, 6 doses they will receive.
Mm.
I cannot hear any voice. Is there any specific voice?
The day progressed. We are in the last.
No,
Nice. I thought this.
okay, enough. Actually, there is not much. You can hear the sounds here in the starting when he was examining again.
Each breath. Go with each breath. You're being awfully sweet right now, aren't you? You weren't so happy first time I came in here. So the interesting story here is you can look at how rapid he's breathing. 1, 2, 3, 4, and you can listen, you can look. When little kids are breathing 60 breaths per minute, they're probably starting to be short of oxygen. Look up here. You can also look right under his neck, under his chin. Look up here. Sometimes you'll see tugging in right here, tugging in between the ribs. This young man was totally well until last night, I believe, right? And then he just started having trouble breathing. Not fun.
So that's it. You can, once 3 minutes finish.
Actually, this video has two parts.
Hmm.
So
So this is a 3-year-old child, John. Okay. Please look at the video and give your comments and history, examination, differential diagnosis, and management. Okay. I don't know if 3 minutes finish.
Yeah, finish.
Okay. You want to start or you have any questions, Dr. Adnan?
So I will have to give this all. There are actually two parts. So I will start, no problem. I can see this 3.5 years old. I can see a child 3.5 years old who is standing with pacifier in his mouth,
Sitting.
and his what?
He is sitting. He was sitting on mother's lap.
In the first he was standing when he was showing.
Okay, continue. See, he is sitting on mother's lap. Okay, continue.
So he's having obvious respiratory distress in the form of uh, subcostal and intercostal sessions, and a doctor is examining him, and I cannot listen any sounds properly due to that
There are expiratory visas. Okay, go
maybe
ahead.
due to poor quality, but I can appreciate only expiratory wheeze was there, and otherwise there was no anything. And in the second part I have seen that nebulizer with via oxygen mask has been started also.
Yes, you're right. Okay.
Okay, so
So what history you want to take?
so it, yes, in the history point, first of all, I would like to ask for the onset, course, duration. As examiner was telling, this is acute because it's happened just in the night. So I would like to ask first onset, course, and duration, previous history of same kind of illness, asthma, or history of hay fever, and history of any allergy, any eczema on the skins, and definitely would like to ask about the history of the triggers which causing these, and would like to ask family history, and
Hmm.
family history, and the triggers like smoking, pets at home, carpeted floors, and dust mite, and family history of similar kind of illness, and the allergy to anything, any drug allergy,
Hmm.
and would like to ask uh, complete history of presenting illness, like if he's having cough, which I cannot appreciate in the video, history of cough, and how is coming with the wheeze, and the timing of the cough, and how frequency of the cough, and respiratory distress as well, frequency of the wheeze as well, waking him waking him from sleep in the night.
Hmm.
So all these
Nocturnal symptoms. Okay.
yeah, all these things, and would like to ask also about the uh, uh, recurrent chest infections are
Okay.
there or not, all these things.
Okay. Next, then in examination, what examination you want to do?
So first examination will be my journal physical examination, and definitely the local examination for the respiratory. So journal physical examination, I would like to see for especially on the skin. First of all, I would like to check for the vitals, heart rate, respiratory rate, definitely temperature and blood pressure. And the child is 3.5, so here is not feasible to check for the PEF and peak expiratory flow, I mean. So, and I would like to ask about the child is fully conscious, but he's having respiratory distress only, is there, but obviously there is no cyanosed or anything. And Further, I would like to do the examination of the skin for the any eczema or any rashes is there, that will give me the clue of allergy. And would like to ask for the I would do the examination of uh, for the respiratory as well. Would like to check for any expiratory wheeze which I can hear in the video also,
And examination,
and the
give,
bilateral air entry as well.
give your differential diagnosis.
For differential diagnosis, I will keep it here acute asthma,
Okay.
and I would like to keep it here cystic fibrosis associated with the asthma as well, and would like to keep the gastroesophageal reflex with the aspiration, and pneumonia and inhaled foreign body, though less likely at that age, but still will keep that one also, and pneumothorax also,
Okay.
because the history is very acute.
Okay. So
But child is not inside.
acute asthma, cystic fibrosis, GERD, pneumonia, inhaled foreign body, and pneumothorax.
Yeah.
So can you tell me how do you want to manage if this child is presenting with acute severe asthma, life threatening? If this child is presenting, how do you want to
Acute
manage
severe or life threatening?
life
This
threatening?
is two different. Okay. First of all, if they present with the life threatening asthma, so first management will be airway, breathing and circulation. I will scare the airway and check for the breathing oxygenation. Definitely that will be in severe life threatening will be less than 92. And I will check for the circulation. He is in shock, but he's not in shock in the video. So I will start with oxygenation, give the oxygen via the face mask or nasal cannula. Then I will give the nebulization with salbutamol with 6 to 8 liter per minute oxygen. And
Nebulization or salbutamol, how it will be in acute, in CV, in life-threatening asthma?
this will be continuous.
Yes, continuous nebulization.
Continuous,
Okay, then.
yeah, continuous. Then we'll give the ipratropium bromide nebulization that can be repeated every 20 to 30 minutes, and we'll give the IV hydrocortisone, and we'll assess if it is not improving. And if it is not improving, I will inform to consultant, and will inform to the pediatric ICU department as well, and will give the bolus of salbutamol, and will assess for the during, if I'm giving the bolus of salbutamol, will assess for the heart rate, and will ECG monitoring, and will check for serum electrolyte, especially for the potassium as well, and will assess for the respiratory rate as well. So if it is still not improving, and I am checking for the saturation, oxygen saturation and CO2 monitoring I am doing, and still not improving, then we'll consider for the magnesium sulfate bolus as well. So far, if I am giving the magnesium sulfate, but that will as the child is more than 2 years of age, so we can give the magnesium sulfate. So for the magnesium sulfate, I would like to monitor for blood pressure particularly, and will assess for the respiratory rate, and
Okay.
uh,
Then,
and
if after
uh,
magnesium sulfate still not improving,
if it is still not in improving, then we'll go for the salbutamol infusion, and continuous for the saturation, oxygen saturation and CO2 monitoring, and will ECG monitoring if there is any changes coming on the ECG, and will repeat this ECG monitoring, and will check for serum electrolytes, potassium as well,
okay.
and that can be repeat every 2 to 4 hours.
Okay. So you will admit the child in pediatric intensive care unit for.
Yeah, getting intensive care, which I have told already,
Yeah.
that if it is not improving my initial, so I will tell to the pediatric consult. I will tell my involve my consultant and
It's
will
still
tell to
not
the
finished.
pediatric.
Nobody is telling me anything. No one kept the time.
I don't
Yeah,
know.
yeah, I'm keeping
Waqt
sorry.
है sir.
Yeah, yeah.
Yasir sir.
Minutes are still.
No. Finish. Time finish.
Okay. But we will just continue. So tell me about the life-threatening asthma. How do you classify the life-threatening asthma? What are the symptoms?
Yeah, symptoms for the life-threatening asthma child will be cyanosed, the first thing, and he will be unstable vitally. That can be of beyond the appropriate for age, heart rate, and the respiratory rate. And the child will have silent chest and cyanosed with silent chest. He may have altered state of consciousness, and PEF that will be less than 33 or less than 33. And but
For
in
children more than 5 years.
for the age of
Tell all.
5 or more than 5 years,
Hmm.
and SpO2 will be less than 92.
Yes, SpO2 less than 92, cyanosis, silent chest, altered level of consciousness, PEF less than 33. And for example, if I take this child, I think he's less than 5 years. So his
Yes.
RR more than 30. His RR should be more than 30. And heart rate should be more than 125. Tachycardic and tachypneic. More than
Yes.
normal values. Along with that, you should see cyanosis, silent chest, altered level of consciousness, and if children more than 5 years, PEF less than 33%, and oxygen saturation less than 92%.
Yes.
Okay? Yes. So you told everything. Yes, oxygen, even if you want, if needed, you can consider till you prepare for nebulization or infusions. He can be on oxygen. In these cases, even high flow oxygen, 15 liters per minute with the face mask with a reservoir bag. Okay. It can even then when we say life threatening, we will start continuous nebulization of salbutamol, and the airflow will be 6 liters per minute. Oxygen 6 to 8 liters per minute. Then, as you said, we will consider ipratropium bromide every 20 to 30 minutes and IV hydrocortisone. After doing this initial management, still the child is not improving, you will involve the consultant and the pediatric intensive care unit. Then you will give bolus of IV salbutamol over 5 minutes. This will be over 5 minutes slowly. And you will observe for 15 minutes after giving this. Still no improvement, you will give magnesium sulfate and it will be over 20 minutes. Then after magnesium sulfate is still not improving, you will consider salbutamol infusion. At that time, he will need PICU admission. Okay, but as you said, continuous monitoring should be there for both salbutamol. And what is the electrolyte derangement you see in salbutamol?
Salbutamol, they may have if we are giving the salbutamol, they may have this hypokalemia.
Hypokalemia, yeah. So they have to be monitored for arrhythmias. So ECG changes in hypokalemia,
Yes.
just in case if they ask you, you know.
In hypokalemia, this will be low voltage of
Low voltage
this
and also
T wave. That can be T for
opposite
T.
to
I don't know.
hyperkalemia. In hyperkalemia, we have what we
And
say?
there can be U waves. U waves can be there.
Yeah, in
Hyper,
hyperkalemia, we say
tall.
tall T waves. So here there will be short, small T waves, and also U wave. U wave will be there.
Yeah, which I told.
Here you can say depressed. T for tented means tent, and for low for down.
You want to you have given feedback if they are calling me now to go for feed.
Okay, nothing. I think you were telling okay, but these people, they did not alert me at 6 minutes. I thought you were taking long time for history. You're taking long time for your time management.
No. He finished at appropriate time, but
No, I think
maybe
appropriate time because I was
he
looking
finished
for the
at
time.
appropriate time, but discussion in between is ongoing. So I said thinking, okay, we'll take it next time.
Okay, no problem. This was my feeling. I don't know. I did not keep the time right. So I was feeling that for
Actually,
history.
here is no particular history. Here is no particular history. So I conclude each and everything. We cannot say particular history, but even for the ample which I was thinking, but it was not coming like it was not toxic looking in the beginning. So that's why I was not, I have not given the ample history.
No,
Here.
no, no, no. It's okay. But for my thing is, I think in the exam they will bring most of the time the life threatening. That's why
Yes.
I was going on. Even though the case is not like that, I was just asking the questions on life threatening because we should know properly about life threatening. For mild, nothing. You will just for mild asthma, there is no this also mild and moderate. There is no ipratropium bromide also. Only
No.
only nebulized salbutamol. No
Nebulized
ipratropium
salbutamol.
bromide also. For this you have nebulized salbutamol and ipratropium bromide. But here you will tell
Yes.
continuous nebulization.
Yes. Yeah.
Okay, so
And also, if continuous not improved, then IV. IV
because
salbutamol.
our differential is pneumonia, you should ask about fever. I think you did not mention fever in your history. This, apart from that, everything was fine. I don't remember you mentioning fever in the history.
Actually, sorry, in all the respiratory, it's better we can say 4 or 5 things, just like fever, cough, coryza, any shortness of breath, any night symptoms. So I think so these 5 symptoms can present in all the bronchiolitis, croup, in asthma. Then we can go particular specific, just like asthma, we have to ask from history for atopy, previous
Your
episode.
point is
And
good. Fever, cough, coryza, night symptoms. And then we can go for family history of asthma, allergy, eczema, past history and triggers, as Dr. Adnan said.
yeah.
Okay. I have only one question to ask for you, Dr. Adnan. So when do you consider that it's a poorly controlled asthma in a child?
What I didn't hear. Sorry.
In a child, to tell that he has poorly controlled asthma or uncontrolled asthma for a child, when do you tell this? What are the symptoms in the child will make you think that he is poorly controlled asthma?
Actually, for that we will have to take the history. His how many times he's taking this and how many symptoms are coming.
Yeah, tell how tell that. I mean, how many
Yeah,
times?
that one is depend upon. There are 4 categories. One is mild, intermittent, then mild persistent, moderate persistent, and severe persistent. So for the mild intermittent, that will become like less than 2 times in a week, daytimes, and daytime symptoms are coming.
I think in the exam, what happens, maybe in the history case you will have long time, but in the video case and all, the time will be short. Just some 2-3 points only. Night symptoms.
Yeah, for that we'll have to take the night symptoms.
Yes.
If it is coming, if it is coming almost daily, okay, or at least, I don't know, forget.
No. See, I will tell you. The question
Yeah,
is asked like this. Just tell simply like this, because we will have many questions, not only one question. So for this question, the answer is more than 3 times the child uses salbutamol inhaler per week. He needs during the daytimes more than 3 times. Not more than 3 times, more than 3 days per week. He needs salbutamol inhaler during the day. I am talking, and even one night he is not sleeping. It is under uncontrolled asthma. Even one night per week is uncontrolled asthma. It means disturbing his sleep. The night cough disturbing his sleep, and more than 3 times per day, 3 days per week, more than 3 days per week, he needs relievers, more than 3 days.
Relievers.
And night symptoms and exercise induced symptoms. In such a case, if you have all these things, you have to consider the patient for, if he is already on preventer, to step up. If he is not on preventer, to add the preventer. That's all. Okay, did you get my point? Hello. Okay, you can go if you we are done. Only this point I wanted to tell you. Hello.
Sorry, my calling is they are calling me. I
Okay,
want to
go,
listen.
go. No problem.
I want to listen actually. Okay. What you said last? Just tell me.
See, from where you are dividing this mild persistent, moderate persistent, because you know, when you tell long answers, they will not listen. I told you before.
Yeah. I know this one better. You have told me this is more than.
Okay, continue.
Yeah, what we advised when we discharge the asthma patient, and what we advise to the parents.
Yeah, discharge, I think he should have more than 94% of oxygen saturation, and his heart rate should be less than 140 for less than 2 years. And there is, according to the age, his heart rate.
Yeah, 140, 125, and 115.
115.
Respiratory and heart rate should be well controlled according to the age. Okay. And SpO2 more than 94%, and they are feeding well. And also, I think 4 hours observation with 4 hours nebulized salbutamol or salbutamol puffs, they are okay, means they are not deteriorating. Okay. And also, I think there is 1 or 2 more criteria. I'm not remembering now. Tell.
Okay, what we have to, no, this is sufficient. What we have to advise to the mother, parents, what they need.
The parents, we have to check their techniques of use of the inhalers or the nebulizers,
that's important.
and we have to teach them, and we have to give them the asthma action plan.
Okay.
And we have to also refer them to the asthma clinic with the asthma nurse. And if the child has presented to us with life-threatening asthma, after discharge, he needs evaluation with pediatric pulmonology specialist. Okay. And another, this is compliance, and this I told you already. I don't know if I'm missing anything.
Okay, and we make sure that they know the risk factors, the deterioration, signs of deterioration, and their action plan.
Red flags, you mean? Yeah.
Yeah.
Yeah, there is an action plan, I think, in my phone. Just wait. Okay, tell if you want to add anything, just add till I open that.
And Dr. Rehana, what are the past history points in asthma?
Past history points in asthma.
Well, it's very difficult to memorize each and everything. Since morning, I am trying to memorize.
Okay, wait. Past history points in asthma will be like how many times
if he has, how many times he,
and how many times he had acute attacks, what teams he is following up with, how many times he has acute attacks in a year, and how is his compliance, and what teams he is following up with, and how many admissions he needed in a year. Okay. And what are
also family history and trigger factors.
Yeah, family history of similar conditions and triggers. What triggers they know that it is from the dust, it is from the pets, and also smoking history is very important. Anyone smoking in
the family.
Yeah, this is very.
And how many days of school he missed. This is also.
Yeah, how many days of schools he missed due to the acute
asthma, because of the asthma attack.
Yeah, the asthma action plan, what you were telling, which you
also the previous number of days he used the prednisolone steroids
per year. Number of courses of
steroids in year, like how many times he required the steroids.
Yeah, how many times you required the steroids. And also when you discharge, always tell in CROUP, in bronchiolitis, and even in this patient, when you discharge, you will give a leaflet. Keep it always common things you should tell in everything. You will give them a leaflet to read about it. For the asthma patient, you will check their techniques and teach them. techniques of inhalers or nebulizers, and it will be taught to them. And also what you will arrange a meeting with the asthma nurse, and if a life-threatening asthma, he needs follow-up with the pediatric pulmonologist, and you will send them with the asthma action plan and explaining them the red flags. Red flags again, what if they ask, you know, the SOB, cyanosis, not speaking sentences, if they cannot speak the words in continuous sentence, right? It will
Become
be
breathless while speaking.
yeah, it will come under severe. If he's not able to speak sentences, it will come under severe. Maybe it is impending to life threatening, right? So also they will be thought about the red flags: SOB, cyanosis, not speaking, not taking food, refusal of feeding, all those things. So
Altered conscious level. And
yeah, in asthma action plan, what will be there usually here? See here, my asthma plan. Okay. So your asthma plan tells you when to take your asthma medicines and what to do when your asthma gets worse. So it will tell about your medicine and asthma. So the name of the child will be written here. So my daily asthma medicines. So it will be written everything, and they should carry with them always. Maybe in the schools also it may help. Okay. My preventer inhaler. For example, here is my preventer inhaler is this, what is this, fluticasone. Okay, they may write flixotide, and its color is orange. Okay, I take 2 puffs of my preventer inhaler in the morning and 2 puffs at night. I do this every day, even if I feel well. This they should know. This is written in their plans. Okay. Other asthma medications I take every day. Suppose if he's on prednisolone or anything, it will be written here. My reliever inhaler is called Ventolin and its color is blue. I take 4 puffs or 10 puffs depending upon the severity. Okay, let's write here 2 puffs. I take 2 puffs of my reliever inhaler, usually blue, when I wheeze or cough or my chest hurts and it's hard to breathe. So these are the symptoms they should be thought when they are feeling SOB, or they hear the wheeze, or there is a cough, or they are feeling chest discomfort and hard to breathe. So my best peak flow is they should record the peak flow, and they should know what is the best peak flow for their age, and whenever they are deteriorating, maybe it will get worse. Does doing sport make it hard to breathe? I told you, even exercise induced asthma, if they are not controlled with exercise, that means it is uncontrolled. They may need escalate the therapy. Okay. Does the sport make it hard to breathe? If yes, I take dash puffs of my reliever inhaler beforehand. Okay. If they have exercise induced asthma, they should take maybe 2 puffs or 4 puffs before going it. Then what the second action here is, when my asthma get worse, what should I do? Okay, I will know my asthma is getting worse if I wheeze or cough or my chest hurts and it's hard to breathe. I am waking up at night because of my asthma. I am taking my reliever inhaler, usually blue, more than 3 times a week. This is what I was telling. Needs reliever inhaler more than 3 times a week. You are waking up at a night. Okay, and your SOB is getting worse. My peak flow is less than. For example, we were checking that I think in severe asthma, it should be less than 55%, right? It is called severe if it is less than 55%. And
less than 50%.
Less than 55.
Yeah, less than 33 is life-threatening.
Life-threatening.
Yeah, so we should know this. If my asthma gets worse, I should keep taking my preventer medicines as normal. Preventer will be normal, and also take dash puffs of my blue reliever inhaler every 4 hours. So this is a 4 hours therapy. When it gets worse, preventer will be same, reliever you will do every 4 hours. If I'm not getting any better doing this, I should see my doctor or nurse.
Or asthma nurse.
This is, remember to use my inhaler with a spacer. if I have one. So they should use. And also there is something, I think less than 3 years, they should use the spacer with face mask. More than
Yes.
3 years, no need. That's it. This is the asthma action plan I have in my this. There is one more. When I have an asthma attack, this is getting worse. Means as I told you, poorly controlled. It means it's not controlled. You have to do something. You have to go to the doctor and increase the dose or add some medication. So when it is too much worse, when I have an attack of the asthma, I am having an asthma attack. If my blue reliever inhaler isn't helping, I can't talk or walk easily. Means you cannot speak in sentences.
Speak in sentences.
I am breathing hard and fast, SOB. I am coughing and wheezing a lot. My peak flow is less than, here you can give 55 or 33. Okay. When I have
Life-threatening is 33.
33. Yeah. When I have an asthma attack, I should see this is an advice. I should sit up, don't lie down, try to be calm. So during an acute attack, they should sit up, they should not lean down. Take one puff of my reliever inhaler every 30 to 60 seconds up to total of
Up
10
to
puffs.
10 puffs. Yeah.
Yeah.
This is life-threatening. You have to take more puffs, 10 puffs.
Yeah, but this is, I think, for severe asthma, this one, 10 puffs.
Yeah, see where until they come to the hospital.
No, every type of asthma.
Let me open here. Wait. I think, yes, you're right. Yeah, 2 to 10.
In that 2 puffs usually we are giving 2
No,
4.
No, 2 to
the
10. 2
guidelines,
to 10.
listen to me. In the guidelines, even for mild to moderate, 2 to 10 puffs you can go. But for the
Every 30
severe, we have
seconds.
written 10 puffs clearly. So for severe, you will go for
See
10.
where life-threatening is 10. Yeah, it's written in that guideline chart also.
Okay.
No,
Okay.
listen. No, life-threatening, you will give continuous salbutamol nebulizer.
Nebulization.
There is no role of inhalers here. Inhalers is
No,
only for mild
severe.
to moderate.
Up to severe. Up to
Severe.
severe.
Up to severe, I'm talking about severe. Severe, you will give 10 or you will start with 2.
No, severe.
Severe,
10
No, no.
10. That's what I read it here in that red chart. Severe 10 puffs.
Yes, Dr. Rehana, wait, I will tell
We
you.
start from 2 and we can take up to 10.
10. Okay.
Even for mild
Okay.
and moderate, you will start with 2 up to 10. But for severe, you will give 10 puffs.
This is what I'm saying. Mild and moderate will start with 2, but in severe you are giving 10 puffs.
10 puffs, but how you will give? Like
every 30 to see that, as they mentioned here, 30 to 60
take
seconds.
one
Okay,
puff
okay.
of my take one puff of my reliever inhaler every 30 to 60 seconds.
Yes,
up to
yeah,
10
yeah.
puffs. Yeah, this
Yeah,
is
because you cannot give him together 10 puffs. You have to take some break, 30 seconds,
Yeah.
60 seconds.
Even if I start to feel better, I don't want this to happen again. So I need to see my doctor or asthma nurse today. So whenever there is an asthma attack, whether it is mild, moderate, or severe, you have to go to your doctor along with doing these things. If I still don't feel better and I have taken 10 puffs here, even if you feel better, you have to see your doctor. After taking 10 puffs, if still not feeling better, I need to call 999 straight away. If I am waiting longer than 15 minutes for an ambulance, I should take another puff of my blue reliever. So after 10 puffs, I am still not well. I will call the ambulance. While waiting for that, if it takes more than 15 minutes, I will take another, maybe, I don't know. You can repeat 10 puffs in 15 minutes, I think. It's same like giving means nebulization. Means if we give 3 doses back to back, right? Maybe like that. Of my blue inhaler every 30 to 60 seconds up to 10 puffs. Yeah, you can repeat it again in 15 minutes. Once you give 10 puffs, you can give time 15 minutes. If still you are not reached the hospital, you can repeat it. Same like we give 3 back-to-back nebulizers like that. My asthma triggers. Wrote down the things that make your asthma worse. So normally, as we know, the dust, the carpet mites, or the this, and what
Pets.
pets. It's any new constructions around the house.
Smoking.
Smoking is very
Smoking.
important. Yeah, I need to see my asthma nurse even 6 months. Every 6 months. Sorry, asthma nurse, they should have follow up, because as the child grows, there are some changes. As we said, below 3 years, they should take with the mask. Above 3 years, they will stop the mask. And also the size of the spacers will differ. I think there is blue, yellow, and red, I think. I'm not sure. Blue is more than 5 years or 2 to 5 years. We have to check this. There are 3 spaces. Do I get my due date? I got my asthma plan. Date of my next asthma review. And doctor and asthma nurse contact details. Everything should be there. Means even if the child carries this card in her pocket, the school teacher or the nurse should be aware. If some attack happens in the school, they should do all these things, like keep her sitting up, give 10 puffs, and call the emergency, call the parents and inform, like this. So they should have the date they got the plan, date next review, doctor and asthma, and even the parents details can be there. Okay, this is the asthma action plan. They can ask about these questions even in the history station as well. Okay, just 1 minute, I will.
And only one thing, always remember this peak exfoliatory flow diaries.
Diary also.
In the history.
Ask them.
See, my doubt is in this page, in the last page. Yeah. But here, in the severe asthma, he has told that you will give salbutamol meter dose inhalers, 10 puffs via large volume spacer plus or minus face mask, or salbutamol nebulized driven by 8 liter per minute. Okay, but here he hasn't given like what we practice. How we practice, we give 3 back-to-back doses, right?
Yeah, our practice here is different. They are telling different.
I don't understand what they are giving. Only one. They are giving only one salbutamol and one ipratropium, like salbutamol.
No. Actually,
how often they are repeating?
Actually, the plan is every 15 minutes they have to continue salbutamol for 4 hours, and then they have to start ipratropium after 30 minutes. That's the reason they are starting this ipratropium after 30 minutes of salbutamol if they are not responding for 2 hours.
It is given in the details inside.
Just like here you see admit nebulized salbutamol means 1 and 4 till 4 hourly, and ipratropium bromide if poor response give every 20 to 30 minutes for first 2 hours.
Where you are reading, tell me.
Admit.
Wait here.
Admit.
Continue oxygen via mask or nebulized salbutamol 1/4 to 4 hourly, means every 15 minutes it is given to 4 hours. This is what you are telling. Okay, I got your point now. Repeat ipratropium bromide if pure response, give every 20 to 30 minutes for first 2 hours. That means salbutamol every 15 minutes, then ipratropium bromide every 20 to 30 minutes.
Yeah, for 2 hours. Then if it respond, okay. If not respond, go to life threatening.
So like this, if you start with suppose
salbutamol. Yeah.
I suppose if I start in the starting for him salbutamol plus ipratropium, both I started because he's in severe asthma.
Okay.
So I give salbutamol plus ipratropium first. Then in the 15 minutes, what I will do, I will just give salbutamol next, because salbutamol is repeated every 15 minutes. Then in the next 15 minutes, again, I will give salbutamol and ipratropium. Like this, I will keep on doing for 2 hours. Right. For the first 2 hours only, you can give ipratropium. That means you can give 4 doses of ipratropium bromide in the first 2 hours. But salbutamol, you can give up to 8 doses, because ipratropium you are giving every 30 minutes. Salbutamol you are giving every 15 minutes.
15 minutes.
After 2 hours, you will just keep on giving salbutamol every 15 minutes. This is what I understand. Right.
Yeah,
Again,
every
again,
15
sorry.
minutes. Every 15 minutes you give salbutamol. Ipratropium bromide.
You did not get the point, Dr. Yasser.
No, sorry, I did not get.
See, what he is telling here, nebulize salbutamol every 15 minutes for 4 hours, right?
4 hours.
And ipratropium bromide every 20 to 30 minutes for the first 2 hours.
2 hours.
So what I will do, I will start at the child with salbutamol plus ipratropium bromide. This is my first dose. Then in 15 minutes, I will give only salbutamol. Then in the next 15 minutes, again, I will give salbutamol plus ipratropium bromide, because I am repeating ipratropium every 30 minutes now. Okay.
No, sorry.
Yeah.
Actually, we have to start first salbutamol, and then we will see after first dose it is responding or not. Okay. If it is not, just like here, because if he respond, he go to the mild to moderate. Or okay. So we give another dose. We give 1 dose of ipratropium, and then we will give steroid, and then we will wait. If he is not improving, we admit the patient. If he is improving, we discharge the patient. If he is not improving, we admit the patient. Then we can give him oxygen, and then we start nebulization 15 minutes for 4 hours, and ipratropium 20 to 30 minutes for 2 hours. Then we assess. If he is improving, he goes to the mild to moderate side, discharge or other. If he's not improving, we go to the life threatening.
Okay, I got your point. So here is the arrow now. If not improving, if no improvement, I am going to this part. Okay, I got your point. In the severe asthma patient, what I will do, I will first give salbutamol nebulization, first dose.
Yeah.
Then no improvement, I will go for ipratropium bromide. This will be the first dose. Still no improvement, I will go for the oral steroids or IV steroids, depending upon the patient's condition.
Yeah.
If still not improving, if discharge criteria is not met, then I will admit him and give him oxygen, and then prepare for salbutamol nebulization every 15 minutes.
Yeah, for 4 hours.
Yeah, it is for 4 hours, and ipratropium for first 2 hours, every 30 minutes. If he is still not responding, I will go to follow the life-threatening criteria. If his discharge criteria is met, I will discharge home. Means I will first discharge and then discharge home. Okay, I got now. Okay. So mostly in the exam, in the video station, you may get either acute severe asthma or life-threatening asthma. So they may ask you what are the steps you treat. So we should know the difference here. For the severe asthma, we just like as I said now. But for the acute life-threatening, you will start with continuous salbutamol nebulization from the beginning. Then with the continuous salbutamol nebulization, you will also consider ipratropium bromide nebulized and hydrocortisone. And if there are signs of shock, you will give IV fluids. But you should also rule out if there is any anaphylaxis role is being played here. If there is any anaphylaxis, consider alternative diagnosis here. Then after doing this initial, if still no change, then you will still continue nebulized salbutamol and repeat ipratropium bromide And then you will consider this salbutamol IV infusion and then magnesium sulfate. Then you have at that point you should also have to consider blood gas and chest X-ray, because normally we are not doing chest X-ray. If the child is deteriorating and he needs salbutamol and magnesium sulfate, then you will do blood gas and chest X-ray.
Chest X-ray.
So what's the role of blood gas here?
To find out the
Because
CO2.
to find the electrolytes and CO2 electrolyte also.
Electrolyte.
Type 2 respiratory failure. If he is ongoing type 2 respiratory failure, then maybe we need intubation.
Also
Yeah.
electrolytes, because you are giving him the nebulization.
Salbutamol nebulization, hypokalemia. Okay.
Hypokalemia.
See here he has written baseline U and E, and also capillary blood gas for potassium. Both you can do either U and E from the lab or CBG also.
From the blood gases are from.
BBG, yeah.
CBG can also give you the potassium level, and ECG monitoring, as I said, for hypokalemia, look for the signs of hypokalemia.
And arrhythmias also, because salbutamol also causing a tachycardia and arrhythmias.
Tachycardia.
Yeah, so record heart rate and respiratory rate and arrhythmias. Okay, just 1 minute. I think this is there. No, we should know very well. What do you do in mild, moderate? What do you do in severe? What you do? And again, here I think with continuous salbutamol nebulization, this is only 1 dose of ipratropium bromide, right? To start with, then hydrocortisone. Then we will continue later if no improvement with 20 to 30 minutes.
Here you are adding hydrocortisone after ipratropium.
Yeah,
because
this is life threatening. He's not able to take orally.
Yeah, you will have to add steroid.
There is no role of oral prednisolone here.
Yeah, because this is life threatening. He cannot take care.
He is not telling DEXA here. Either prednisolone or hydrocortisone. They are not using DEXA in UK or what? Here in our practice.
DEXA for what?
We use dexamethasone for.
No, DEXA only for laryngeal edema. Only.
No, DEXA not here. Here you will use hydrocortisone or prednisolone in apnea underlying.
So apnea, any underlying cardiac defects, especially large left to right shunt. So cardiac defects we have to mention, shouldn't forget. SpO2 less than 92 in air in a child with early phase of illness, means starting only he's come in a deteriorated way. That is what they are telling. Early phase of illness means he came to you, but he looks deteriorated.
Unwell. He looks unwell.
Yeah. So less than 92, cardiac defects, apnea, feeding less than 75%, dehydration, and diagnostic uncertainty. You are not sure it is just bronchiolitis. Okay. Then another relative is what we say in our hospital, we say second visit. Second visit, you should always be cautious. So re-attend CA and E within 48 hours. What is CAU here?
Where is he?
I don't know what is CAU.
This CAU is, yeah, I wrote it here. This is
means they came to you and within 48 hours they are coming back to you. There is some problem you have to consider here. Okay.
So this is child assessment unit. Child assessment unit, because I checked it. What is it here?
Okay, thank you.
You have to send the child assessment unit.
Yeah. So always remember, when the child is revisiting you or when the parents are revisiting you, you have to take it seriously. Means there is something problem. That's why they are revisiting you. So re-attends accident and emergency and child assessment unit within 48 hours. And age is less than 6 weeks, as Dr. Yasser was telling, less than 6 weeks. You have to consider antibiotics also, as sepsis, pneumonia. Okay. So
especially if they have fever and this signs of sepsis, you have to start it.
Yeah, tachycardia, hypotonia, tachypnea. So less than 6 weeks, there is a chance that you should involve your consultant and may need antibiotics. Difficult family circumstances and impaired ability to care the unwell child. That is social problems.
Social,
okay.
Yeah.
And age less than 9 months. Sorry, a younger child aged than less than 6 months and presenting in illness earlier in illness. As I told you, they came and they are
Deteriorating.
They are deteriorating. That means less than 6 months and presenting earlier in illness is also relative, and pre-existing lung disease, including chronic lung disease, ex-preterm cystic fibrosis. See, for lung disease, he has put relative, but for cardiac, he has put absolute. Have to be keep this in mind. For cardiac defects, it is an absolute. Any child with cardiac defect presenting with bronchiolitis, he is for admission. But for the lung disease, you can consider as relative. Chronic lung disease, ex-preterm cystic fibrosis, inform specialty consultant. You will take the reference from the consultant. Other pre-existing chronic disease, for example, any neurodegenerative disorders. But see, when they ask, even if we don't tell everything, at least important points you have to tell, like apnea, child with cardiac defect, feeding less than 65%, SpO2 less than 92% in the early phase of illness, like this. So next is the monitoring treatment.
Standard nursing observation, continuous oxygen saturation.
Yeah, standard nursing observations, and always remember those points we said in the starting. Nursing in a cubicle and in or in a
With
bed,
the same diagnosis.
head nurse up, means nursing with the head up. These points are very important, and suction.
And hygiene. We are apron to avoid infection. Yeah, and
yeah, consider continuous oxygen saturation monitoring if patient needs supplemental oxygen. Then instead of every time doing a CBG to check the CO2, you can do transcutaneous CO2 monitoring if available. If available, you can go for transcutaneous, or SpO2 less than 90% in nasal prongs. Okay, with high flow oxygen. He's telling approximately more than 60% oxygen means high flow, right?
Yes, high flow. They said na humidified high flow oxygen.
Yeah, or history of apnea or color changes. You have to monitor them. Continuous heart and respiratory monitoring if patient requires additional respiratory support. So in such patients, you can admit in PICU as well. So this is very important. Fluid balance, oxygen support. Test need for support every 6 hourly. Keep oxygen saturation more than 92. Wean from nasal progs to air as tolerated. So weaning also you have to consider. As soon as they are improving, weaning should be considered. Even if the child is on CPAP, weaning has to be considered. Then discharge home. You will discharge only when he is feeding adequately, fully fed orally. SpO2 more than 92. Hospital follow up if he will be followed up with the GP. If he was ventilated in the PICU, that means he needed ventilatory support. Consolidation on chest X-ray. First reassess clinically. Do not request routine follow-up X-ray, but repeat if clinical examination to follow-up is abnormal. So you did chest X-ray and there was pneumonia. He will be followed up in the oxygen and ex-preterm with chronic lung disease. Otherwise GP follow-up. These points they will ask, very important. Criteria for admission and when do you discharge and what are the follow-up for the discharge. Rest all Dr. Yasser told before. Only one thing last. I think in 5 minutes we will finish it off. 67. So as in our case, there was stridor at rest, right, Dr. Rehana?
Stridor at rest, yes.
So it will come under severe. This is very important point to tell to the examiner, whether you are hearing the stridor at rest. But even in the moderate, there is intermittent stridor, in the moderate. But at that time, you will see child sometimes without stridor. In the video, intermittent stridor at rest means he is at rest. Sometimes you are not hearing stridor. If you are hearing continuous stridor at rest, it is severe CROUP. And also you may see some features of cyanosis. And if there is attached to the SpO2, it will be less than 92%. And recessions. In our child, there were recessions also.
Recession.
The saturation was not given, and cyanosis was not clear. You can say maybe, may not be. Okay.
I said, yeah, maybe, because only the oral area was having some cyanosis.
It was not clear, but I think in exam it will be clear. This is very important point. No IV cannulation, no investigations necessary. Not attempt to take blood or put cannula. And if diagnosis is unclear, severely unwell, call consultant immediately. So in mild to moderate group, always you will give analgesia. I don't know whether you mentioned this or not. We have to mention this.
Analgesia, I did not mention.
And good fluid intake. Leaflet. Always when you discharge them on leaflets. Very important. Leaflets and reassurance for all. Then oral dexamethasone. 150 micrograms per kg. Admit and observe moderate croup for 4 hours. So any moderate croup you will observe for 4 hours. That means a child who has intermittent stridor, you will admit him and observe for 4 hours.
Observe for 4 hours.
Then dexamethasone can be repeated after 12 hours. This is what I'm telling. If the child is admitted and if he is there with you in the hospital, repeat after 12 hours. But if well and patient can be discharged, then you have to discharge with a single dose of prednisolone 1 mg kg round up to nearest 5 mg to make up 12 to 24 hours later. So either you admit, you will repeat dexa after 12 hours, or when you discharge, you will ask the patient to take it after 12 hours. Okay, 12 hours. Give prednisolone to them. If parents do not clearly understand what to do, do not discharge. You explain to them. They are not understanding. You think that they did not understand. Don't discharge the child. Admit the child with you, even with moderate croup. Okay.
If the parents did not understand.
Yeah. If they understand and they can give the second dose of dexa and he's better after 4 hours. Okay, no problem. Then in severe croup, this is very important. Keep the child and parents calm. Do not upset the child. And even by forcing oxygen mask onto face or examining throat, when you tell nursing here, there we said we should nurse head up. Here you should say nurse on parent's lap. And in a position they find comfortable. Either the most comfortable is parent's lap. Even I have seen many pictures in other books in epiglottitis. They keep it on the parent's lap in upright position. Okay. So nurse in the parent's lap or in position they are comfortable. Usually start with high flow oxygen, 15 liters per minute via mask with reservoir bag. And dexa again 150. If they don't tolerate orally, you will go for budesonide 2 mg. Then adrenaline 400 micrograms per kg, maximum 5 mg. So, or you can remember 0.4 ml or 0.4 mg also. Okay, and it will be usually nebulized adrenaline will be 1:1000 strength. Okay, why this is given? Because to relieve the symptoms while dexamethasone and budesonide start to work. It has short duration of action, so you can repeat it after 30 minutes.
30 minutes.
And still the child is not good. If severe enough to require nebulized adrenaline, likely to be admitted. If he is severe and you are giving adrenaline, at that point you should consider admission. If considering discharge, ensure observed for more than 3 hours. If you want to observe after giving adrenaline, budesonide and all those things, you will observe him for 3 hours in your admission. Then if still not improved, on-call consultant, ENT surgeon and pediatric anesthetist. If no sustained improvement with adrenaline and dexamethasone, secure airway in theater. Tell this, very important. You will secure it in the operation theater by experienced anesthetist. And then transfer to PICU. Leaflet on croup, antibiotics, antitussives. See, no need to give. Generally, they are giving, right? Some antibiotics, some antitussives, like this Aries, loratadine, something and all. No need of all these things. And humidified air do not help. See, the humidified air is more helpful in bronchiolitis, right? Heated, humidified air.
Humidified. That's high flow, na? Heated, humidified.
Yeah, but
That's for
here,
the bronchiolitis, but here no, here
it is
I
not
think only
mentioning. Here nowhere he mentioned the heated humidified air. He just mentioned high flow oxygen here.
he said here only the high flow. He said here antibiotics, antitussive, and humidified are not helpful here.
Yeah,
Do
do
not
not-
help.
Yeah, so encourage fluid intake. More fluid should be taken. Then advise parents to seek help. Red flags. Red flags. What you will give the parents? Drooling,
Drooling,
labored
fever,
breathing,
respiratory
SOP,
distress.
yeah, persistent fever, and
Fever.
biphasic or worsening stridor, cyanosis, reduced level of consciousness, all these things. We know the cyanosis and reduced is like severe it is. What about this biphasic means both inspiratory and expiratory stridor?
Yeah, that day you remember that he was saying, I said inspiratory, he said it can be both inspiratory and expiratory biphasic.
No. In foreign body, there it should be. So just to see.
So there's just to
And-
exclude the foreign body, you mean?
Yeah, foreign body and severity of the croup. Initially, when there is severe croup, there is biphasic. And if it is worsening or something, you also think for foreign body because all are differential, just like persistent fever for tracheitis, bacterial tracheitis, for drooling for epiglottitis, labored breathing already croup versus is epiglottitis. So biphasic sometimes can occur if the croup worsen. So there is biphasic stridor and also occur in foreign body
So biphasic means both inspiratory and expiratory.
and bone expiratory. Yeah.
Okay, but normally stridor is inspiratory sound.
Inspiratory, yeah.
Sometimes
Ideally,
if worsen, you can have biphasic, and also in
biphasic.
foreign body, you can have biphasic. And labored breathing means shallow breathing.
Labor
Like-
breathing could
Yeah.
be
Yeah.
Labor
With it-
breathing can be fast also, no? Fast breathing.
just
fast
just
breathing.
like air hunger, just like
Okay, no need to follow up for group. But always remember, common points you should tell is I will educate the parents, or I will counsel the parents. I will give them leaflet to read about it. These 2 points should come every time. You will counsel, educate the parents, give them leaflet on the condition, whatever you're speaking, and some things which will not use. Like in bronchiolitis, you will say, I will not use antibiotics, I will not use steroids and normal nebulizers like this. Here you will say, no antibiotics, antitussives, no humidified air, only fluid intake, analgesics, and all other drugs. And this is the drooling mainly for the epiglottitis, persistent fever and increasing toxic maybe for bacterial tracheitis. Worsening stridor can be again severe croup or foreign body. Cyanosis, reduced level of consciousness, can be a feature of severe croup. Okay, so the saturation which has to be remembered, standard is 92%, even in croup, even in asthma. Less than 92% will come under the category of either severe croup and also severe asthma and life-threatening asthma. Okay, 9:15 now, so we will end the meeting.
thank you.
Okay, thank you.